May I invite Dr. Jayan Stephen, please? Associate Professor, Department of General Surgery, Government Medical College, Wayanad, next.
Welcome, Dr. Jayan Stephen, actually the king of Wayanad, for the next presentation.
Dignitaries on the dais, distinguished guests, senior leaders of ASI from headquarters, senior faculty members, colleagues, and my dear friends. First of all, I would like to thank the organizing team of Kasicon 2024 for giving me an opportunity to present before this august crowd. And I would like to congratulate the entire team of Kasicon 2024 from the dawn, Dr. Srijayan, Dr. Arun, Dr. Alexuman, Dr. Rameshan, Dr. Dibin, and the entire crew for this wonderful conference. And it was last day, it was a meticulously planned and executed workshop. And this crowd, in the recent years of ASI, this is the conference with maximum participation. Congratulations to the entire team of Kasicon 2024. I bring greetings from Wayanad Medical College, and my talk is on understanding the evolving landscape of office procedures in proctology. From ancient times onwards, the many invasive methods in treating the anorectal conditions were described. In history, Hippocrates used high temperature to cauterize bleeding hemorrhoids, and in ancient China, they were used aggressive chemical mixtures to coagulate. And it's all because of the favorable anatomical feature of anorectal zone, that is absence of pain receptors above the dentate line. For a common man or a mediocre medical man, any problem around the anus is called as piles. And the biggest problem is, even though in Kerala we have 100% literacy, 70% of patients with anorectal diseases first consult a cock in Kerala. It's because of the reason that their advertisement that 100% effective, no cut, no stitch, no scar, no pain, no recurrence, no anesthesia, and no complications. And from the cocks, we have to pull these 70% to our setup. And a daycare clinic is defined as an institution in which patients undergo elective operations the day of their admission and are discharged within 24 hours after surgery. Its goal is to avoid unnecessary hospitalization while providing the same quality of treatment and personal satisfaction as given in inpatients. In general practice, the majority of surgeons prefer to carry out surgeries, even minor ones, at large multi-speciality hospitals. A significant number of procedures that do not require special equipment, pre-operative preparation, and hospital stay are realized in these inpatient setups. This has resulted in long waiting list of hospitalization, shortage of beds for major surgeries, high cost of bed, and a significant burden on limited resources. This hospitalization with elevated cost has determined the need for a revision of these concepts, culminating in many surgical procedures moving from hospital environment to outpatient sector. The rediscovery, improvement, and broadening of outpatient resources and utilities have occurred in last century, and the first outpatient clinic was established in Michigan, USA in 1961, and in 1962, two other centers were started in USA, and the good results achieved by these centers simulated the interest of other hospitals throughout the world. In general, 30 to 50% of all surgeries can be safely realized in outpatient sectors. But in proctology, up to 90% of anorectal disease can be managed in outpatient sectors with social, economic, and medical benefits. So, how we choose patients for outpatient treatment? Patient with good control on systemic disease, ASA 1 and 2 levels, not on anticoagulant treatment, or they have to discontinue the anticoagulant treatment 1 week prior to the procedure, The patient should be accompanied by a responsible person to take him home and stay with him for the next 48 hours. Assurance of active participation of family members in post-operative care, and patient should have easy access to toilet and telephone. He should have a quick transport system in case of emergency or complications, and he should have immediate access to medical facilities. Coming to the pre-operative investigations, only we need routine hemogram including hemoglobin level, bleeding and clotting time, blood glucose estimation, and estimation of HIV, HCV, and PSAG. Patients over 35 years of age were evaluated by a physician to rule out cardiac or other systemic disease, and an ultrasound scan abdomen to rule out silent BPH. Preoperatively, 17.5 gram of polyethylene glycol solution in the previous day night. No enema was given. Patients were asked to pass stool in and urine before the procedure. Usually under pudendal block plus local anesthesia or sedation. The organization of procedure is admitted an hour prior to the procedure, lithotomy, jackknife, or Symes position as the surgeons desire. No local preparations except for pilonidal sinus. After disinfection of the operative field, the procedures were carried out. No intra-anal dressing was given excepting coverage of external wounds by an absorbent pad. Kept under observation in the ward for the next 6 hours to contain vomiting, urinary retention, pain, or post-anesthesia events if any. The wounds were checked and the dressings were renewed if found necessary in case of undue bleeding or soiling. The patients received a leaflet exhaustively detailing essential post-operative care along with dietary instruction and a detailed prescription for sitz bath, dressing, application of ointments, analgesics, and laxatives. They were provided with a telephone number to call any time in case of encountering any complications. The patients were discharged once they passed the urine, had started taking oral feeds, and been administered a dose of analgesics and were able to go to the toilet alone and dress themselves. Post-operative care is warm water sitz bath immediately after each defecation and again at bedtime, cream containing local anesthetics and antiseptics twice a day and as and when they felt pain and passed a stool. Systemic antibiotics for infective pathologies like anal fistula abscess, liberal use of fiber supplement and stool softener. The routine analgesics prescribed were paracetamol, tramadol, and diclofenac. So, once you set up an outpatient care, you should always gain the confidence of the patient and you should examine in a good light under whatever position you like. And always no one is happy to expose his anus to the surgeon or anyone. So be gentle, respect towards patients with soft words and politeness. And inspection is very important. Usually it is the most neglected part. You can identify all these by inspection alone. And the second thing is a digital rectal examination. And it's a must-do thing. And you can check all these things in the digital examination part. And absolute contraindication for a digital rectal examination is if the surgeon has no fingers or the patient has no anus. And even though we are doing all the perrectal examination without taking consent, in this era of medical litigations, make it a habit of a written consent before going for a PR examination. And sigmoidoscopies should be done as a precaution in every case to rule out any cause higher above. The office setup should contain adult and pediatric anoscope, proctoscope, and retractors, one motorized examination table and a positional light, minor surgical tray of instruments for cutting, grasping, holding, and so on, biopsy instruments, cautery, and suction, and chemical agents are necessary to deal with growth, podophyllin, trichloroacetic acid, etc. The most important part of this office procedure is a pudendal block. You have to take 2 cc of lignocaine for local anesthesia, and then 8 cc of 0.5% bupivacaine with 4 milligrams of Dexona is given for block. This is a nerve detector, nerve stimulator needle. This is the nerve stimulator, and you can palpate the ischial tuberosity, and you should be very gentle, and you should give 2 cc of local anesthesia. And once you have given this 2 cc of local anesthesia, then you can take the nerve detector needle and direct it to just medial to the ischial tuberosity. Carefully you can apply, you can start with a 1.5 milliampere of current, and you just look, you can get a perianal twitchings, you can see it now. So you should be specific, and at that point you can reduce the current to from 1.5 to 0.4. Then the needle will be very close to the pudendal nerve, and you can inject the 0.5% of bupivacaine. It's a very good, and you can do almost all procedures by this block. So once you have given this bupivacaine, the twitchings will stop automatically. So under this we can do for pile sclerotherapy, Barron's ring application, infrared coagulation, evacuation of thrombosed hemorrhoids, in Fisher-Nano, lateral sphincterotomy and botulinum toxin injection, anal fistula, waft, plug, glue or lift, and glue therapy for fistula, in pilonidal cyanide, Epsid, Silat, Valapse, all of them were described by Dr. Kushal on last day, and less common conditions like anal wart, condyloma, rectal polyp, suture, drain, seat and removal, skin tag excision, issue-rectal abscess, IND, biopsy. And if you have a scope with you, you can do so much things, and you can do a suture ligation of hemorrhoidal arteries under this block, and you can do even a stapler hemorrhoidectomy. And one word about partial prolapse or obstructed defecation syndrome, or ODS, the stapled transrectal resection of the rectum called STAR. This syndrome is characterized by straining a stool on more than 25% of occasions, the need to self-digitate, a sense of incomplete evacuation, laxative abuse, or the use enema to achieve bowel evacuation more than once per week. Physical examination may reveal a rectocele and an occult rectal intussusception. Assessment of these patients prior to consideration of a STAR procedure is best done in conjunction with a gynecologist and radiologist who have a special interest in pelvic floor disorders. Coming to, you can do also this transanal endoscopic microsurgery under this. In short, a man who is tired of his anus is tired of his life. It's our responsibility to inform patients of the availability of various modalities with their pros and cons, and let them make an informed choice. Thank you. Thank you very much.
Thank you, Dr. Jayan, for the nice presentation. Under pudendal block, you can do anything in the rectum. I have one comment to add. In this office procedures like sclerotherapy and band application, you can do even without anesthesia, so above the dendrite line. And
how frequent do patients come back with complications? I mean, do they contact?
Most of the time, the usual complication is urinary retention. That's why in the preoperative preparation, I said you should do an ultrasound abdomen to identify any grade 2 prostatomegaly like that. This is the main problem.
Very excellent, excellent presentation, Jayan Stephen. As Jayan Stephen rightly said, most of the anorectal problems goes to quacks, because even in this literate crowd like Kerala, many are very reluctant to say they have a piles or other in the public, because we know that when they are going to a hospital, when they are meeting a familiar face, what is your problem, they are very reluctant to say I am having piles. So they will very secretly go to a nearby coax, and they will come to surgeons only when they are getting complications. So we should have a good education also about the complications that can happen when they are going to the coax also.
Thank you.
Thank you, sir.
I have time, yes, just one comment. I like your contraindication for digital rectal examination. It's a very good message. Like, you know, we learned from like McGregor's anatomy If you don't put your finger in the rectum, you will put what?
Feet.
Yeah, put your foot in it. I just want to ask you, is it necessary to do sitz bath? You are recommending
Actually,
very much.
literature wise, it will increase the vascularity. So, in all this office procedure setups and all, they advise this sitz bath. And sitz bath, BD, and immediately after passing stools also.
Thank you, sir. We'll have to move forward.
Thank you.
Thank you so much, sir.